Our next session is the rapid fire session. My name is Charles Hu. I'm the president of the Arizona Trauma Association. We have 4 interesting presentations in the next hour. 4 surgeons from our trauma centers in the Phoenix area. In the interest of time, we won't have any Q&A session after the rapid fire session, but feel free to ask some questions and afterwards. I hope that you'll find these presentations informative and thought-provoking. So let's begin. First up, we have Dr. Jeffrey Salomone. He's the Trauma Medical Director at Banner Desert Medical Center. He's a past president of EAST and former member of the American College of Surgeons Committee on Trauma and former chair of the EMS Committee. Dr. Salomone.
Thank you very much, Charles. I appreciate the invitation from the Arizona Trauma Association to speak today. My background before medical school was in EMS. Are there EMS providers here? Okay, thank you all for the job you do every day. It's always easy to put an IV in a room that's 72 degrees and it's not raining. There isn't broken glass all over the floor. And the room's not moving at the time, correct? So if you work in an ED and you've never spent time in the pre-hospital environment, I truly encourage you to gain some experience riding with one of your local EMS agencies. I was asked to speak about a brand new position paper that was just published in Pre-Hospital Emergency Care. Honored to be one of the co-authors of this paper. It was actually e-published several months ago in August, and since that time has been the most downloaded paper from pre-hospital emergency care in their history. So it's on spinal motion restriction, and let me give you a little bit of history about this. Before I get started, I have nothing to disclose. History of this is that back in 2014, when I was chair of the EMS committee for the American College of Surgeons Committee on Trauma, we worked with the National Association of EMS Physicians to craft a paper on indications for spinal immobilization. And that is because in some ways the COT, as a conservative organization, I don't mean politically conservative, but medically conservative, was slow to evolve with some of the changes that were occurring in the EMS community about spinal immobilization. I mean, ATLS has always said, board them all, collar them all, and it took a while for the Nexus criteria to get into the ATLS course. But we worked with the National Association of EMS Physicians and put together a position paper that was published in 2014. There were some less conservative or more medically liberal members of the National Association of EMS Physicians who really felt that the paper didn't go far enough. And so they went to their home organization, the American College of Emergency Physicians, and in the EMS committee there, there's the monitor. In the EMS committee there, they authored a position paper that was far more liberal in terms of what you could do or not do in terms of spinal immobilization. So that kind of set up 2 national organizations or 3 national organizations having conflicting positions about what EMS providers should do. And that also becomes an issue for organizations like the National Registry when it comes time to write exam questions for board certification as an EMS provider, because what might be the right answer according to one position paper is the wrong answer according to another position paper. So the College of Surgeons brought in colleagues from again, the American College of Emergency Physicians and the National Association of EMS Physicians, to agree on a collective position that everybody could stand behind. And this is the paper that was just put out. So I'm going to walk through the points of consensus. Many of them I think are very straightforward and won't be a surprise to you. The paper is, even if you don't subscribe to pre-hospital emergency care, it's one of the papers you can download for free from their website. It's only about 3 pages long. So some of these are no-brainers. Unstable spinal column injuries can progress to severe neurologic injuries in the presence of excessive motion of the spine. So I'll agree with that. So this is one of the things that I was really a dinosaur on. I grew up using the term spinal immobilization, and it took me 2 decades to evolve to the idea of spinal motion restriction. To me, it's just, I'm not very politically correct, and it just seemed like a politically correct term. It's true we can never fully achieve immobilization, and spinal motion restriction really communicates that idea of what we're trying to accomplish. The goal is to minimize unwanted movement of the spine. So again, the position paper is recommending getting rid of the term spinal immobilization and moving towards spinal motion restriction. So historically, backboards have been used for spinal motion restriction. Here is where the paper begins to evolve a little bit. The paper says, yeah, you can continue to use a backboard, but there are other devices that EMS can use that will still accomplish spinal motion restriction. Whether they are scoop stretchers shown at the top here, and if you're not familiar with this, it's a device that breaks in half, and you slide it under each half of the patient, lock it together, and you can pick the patient up. Very limited movement doing that. And the bottom one is something that's real popular in Europe, not so popular in the US. It's a vacuum mattress. You slide the patient onto this mattress, wrap it around the patient, and then suck the air out of it, and it holds the patient in immobilization. And the other thing they said they could use is the EMS stretcher or similar device. So you can accomplish spinal motion restriction not on a backboard, but on an EMS stretcher. So that's a change. Many people have used the Nexus criteria and it's been about 2 decades since they were published. So indications for SMR are the opposite of the Nexus criteria you'd use to clear a patient. So if a GCS is less than 15 or evidence of intoxication, you'd do SMR. Midline neck or back pain or tenderness, focal neurologic symptoms, numbness or weakness, if you palpate an anatomic deformity of the spine, and distracting injuries or some issue that impairs reliable exam. Communication problems or mental health issues would fall into that category. So when spinal motion restriction is indicated, it should be applied to the entire spine due to the risk of non-contiguous injuries. So in adults, it's known that if you break your spine in one location, there's about a 5 to 10% chance you may have a fracture at another location. So here is a change from the advice that ACEP was giving folks, where they said that it's okay to put a C-collar on somebody and sit them up and bring them in on a gurney. Whereas this current paper is now saying you need to keep, if you are believing this patient needs spinal immobilization, you need to keep the head, neck, and torso in alignment. And this can be accomplished with a backboard, scoop stretcher, vacuum mattress, ambulance stretcher. And that if the head needs to be elevated, you need to elevate the device that they are on, rather than put the patient in a sitting position. So here's a picture out of Lee County, Florida. This is no longer considered acceptable by this paper, and doing something to elevate backboard or vacuum mattress to raise the head of the bed if you need to. One of the things we know is that the greatest risk to the spine is during patient transfers. So all patient transfers create the potential for unwanted displacement of an unstable spine injury. And so it's recommended that when you're moving a patient, to the ground, to the ambulance stretcher to the EMS gurney, that there be some sort of device used, a backboard, scoop stretcher, vacuum mattress, to assist with patient transfers and minimize the movement of the spine. Here is another advancement, is that once the patient's safely positioned on the ambulance cot, you can remove that extrication device that was applied, whether it's a backboard, a vacuum mattress, a scoop stretcher, provided there are adequate trained personnel to minimize unnecessary movement of the spine. So again, that concept of spinal motion restriction. But they recommend that the EMS providers weigh the risks to patient manipulation and the benefits of removing the device. So if you've got a 5-minute transport, probably less likely that you want to remove it compared to a 3-hour transport where the patient's going to be laying on a rigid spine board. So consider transport time, and if the device is removed, you still need to maintain spinal motion restriction. That is, log roll the patient off a backboard or something, keep them on the ambulance stretcher, and secure them to the ambulance cot so that they're not moving around. So they are still restricted, their movement is restricted. This comment made me think a little bit about some of our practice in the emergency department. Sometimes we just lift patients onto the gurney. And now if they're on a spine board, we move them over on a long spine board. But again, hospitals should be prepared and equipped to carefully and quickly remove patients from that spinal immobilization or extrication device. So a backboard, scoop stretcher, and so forth, as soon as possible after patient arrival. And this can be done with a slider board, and again, it emphasizes the need for the hospital emergency department to have trained personnel for this transfer. And then the last thing related to adults that they emphasize is that there is absolutely no role for spinal motion restriction in penetrating trauma. And this has been borne out by several studies. A large national trauma data bank review published almost a decade ago by Elliot Hout out of Johns Hopkins, as well as some other more recent data. And East has a clinical practice guideline on this topic as well. So if a patient's shot, their chance of having an unstable spine injury is virtually zero. And even if they do, their medical problems, potential internal hemorrhage, takes precedence over that spine, and you move them as rapidly as possible. There are just a few pediatric considerations that are included in this, and I'll go through them. And this is emphasized that age alone should not be a factor in decision-making for children. So if you believe you can have a reliable conversation with the child to clinically clear their cervical spine, then that would be acceptable. So even though young children pose communication barriers, it shouldn't be mandated SMR purely based upon the child's age. The indications for cervical collars in children are complaint of neck pain, torticollis, that is, they won't turn their neck, neurologic deficit, altered mental status or intoxication, and involvement of a high-risk mechanism, such as a high-risk motor vehicle crash, high-impact diving incident, or a substantial torso injury. As opposed to adults, it's felt that the evidence supporting non-contiguous multilevel spinal injury in children is very low, in fact, non-existent. And so in this setting, you don't necessarily need to worry about keeping the whole neck and spine in the same alignment. They do emphasize minimizing the time on backboards with consideration of the use of vacuum mattress or padding on a long backboard to minimize pain and pressure ulcers. So lastly, this is something, if you've been doing EMS for any number of years and taking care of children, something that's always been taught in children under the age of 2 or 3. Their occiput is very prominent, and if you lay them flat on a backboard, they get hyperflexed, and so padding behind their shoulders and torso allows you to maintain the patient in neutral inline position. So if they are going to be put onto a backboard or vacuum mattress or device like that, they would need to have some padding there to keep them in a neutral inline position. Now, this paper, prior to publication, it was sent out to a number of national organizations, and it has been endorsed. Now, remember, it's authored by the American College of Surgeons Committee on Trauma, American College of Emergency Physicians, and the National Association of EMS Physicians. But these 12 organizations have also endorsed it. So there's a lot of national support. The American Association for the Surgery of Trauma, Eastern Association for the Surgery of Trauma, Western Trauma Association, the National Association of State EMS Officials, National Association of EMTs, the Society of Trauma Nursing, National EMS for Children, the Pediatric Trauma Society, National Association of EMS Educators, the American Pediatric Surgical Association, American Academy of Pediatrics, and the Emergency Nurses Association. So with that, I'll conclude my rapid fire session, and at the end of the meeting, I'll be in the back in case anybody has any questions. Thank you very much for your attention.